This is my inaugural talk on a very basic topic of rationale for imaging in PCI. We all know that our standard tool for imaging coronary is coronary angiography. It has several limitations, we know. Coronary is a three-dimensional structure, and we image two dimensions on coronary angiography. So if you have a lesion which is eccentric in three different views, we try to view them and they look variable in terms of stenosis, 20%, 40%, and 60%. There is no way we can read morphology, no way we can read the calcium. But kind of cases that we are seeing are very, very complex. Because of the advancing age, several patients have, and we are doing PCI on very complex lesion with calcium. Coronary angiography itself is very limited tool for detection of calcium, and the best is intracoronary imaging, OCT, first, and then followed by that, IVUS, equally good. This slide has surprised me, and it will astonish you also, that if you use a 3 millimeter stent and dilate it to 16 atmosphere, it will expand up to 2.43 millimeter. And this has been something which has been proven by 4 studies, 2001, 2005, 2007, and 2010. It shows that the average diameter that we get is 75% as per the compliance chart. We don't get 100%. So we can conclude that manufacturer compliance chart cannot be used to guarantee the adequate stent expansion. So what chart we should have then to decide whether adequate stent expansion is there? We should have this chart at least for complex subset in the cath lab, which says that 3 millimeter is 7.2 square millimeter. So, and then reason being, most of the studies have shown bigger the MSA, lower the TLR. What are the predictors of restenosis or stent failure or thrombosis? Mainly, these studies have revealed there's under-expansion of the stent, and next best is geographic miss, edge dissection. And rest that we are talking are very few. And so optimizing stent becomes very important, and this algorithm has been set up to optimize the stent. If we follow this, we have a great result. Now, most important thing is outcome, particularly the mortality outcome. So far, we have spoken largely on the primary endpoints, but outcome, that is death, unambiguous parameter clinically. So there are about 24 randomized trials, 34 meta-analysis, and 80 total registries. So several data is there. And this data has revealed major meta-analysis combined with RCTs and non-RCTs, such as that overall there are 35% reduction in mortality in IVUS-guided PCI. If you compare the randomized trial of IVUS-guided PCI versus angio-guided, the mortality reduction is 50%. And this is meta-analysis reported in Circulation Japanese Journal, and it suggests, the meta-analysis suggests that there is 56% reduction in mortality. So overall, mortality reduction is also expressed by 2 large trials. 5 years data are available, IVS XPL and Ultimate trial. And both these trials have clearly demonstrated that the benefit continues to grow over a period of 5 years and 3 years. So, and that is remarkable. When it comes to a specific data pulled from these data, primary data pulled from the patient, that suggests that there is actually total definite 50% reduction in mortality. There was earlier OCT and IVUS, old-fashioned IVUS, had problem of discrepancy in measurements, but HD IVUS and OCT studies have shown provide almost similar measurements, no difference at all. Then meta-analysis, IVUS versus OCT, both are equally good, no difference at all in cardiac death or primary endpoints at all. Then coming to the calcific nodule, which is supposed to be the third most common cause of ACS, and there also we can see the clear-cut benefit. And for any calcium, we have an algorithm to decide what tool to use for modification, and we follow that. So if you use IS-guided PCI, if you do IS-guided PCI in calcific lesion, it's definitely superior to angio-guided PCI, and the difference is statistically significant in terms of mortality. Then we have this IVUS in Leftman against FFR, and that is shown that if FFR is 0.75, it tallies with the IVUS 6 millimeter only in Leftman. Non-LMCA lesion, it doesn't tally that well. So we have this algorithm we have to follow where to say that Leftman is ischemic based on IVUS study and do a PCI. And if we do the PCI and based on FFR or IVUS, the death-wise difference numerically little less in IVUS in FFR guided, but statistically not significant. So meta-analysis of IVUS versus angioplasty guided DES implantation in LMCA, which is the most important complex lesion that we do. And it suggests that all-cause mortality is reduced by 41% and cardiovascular mortality by 61% if you do PCI in Leftman IVUS guided. So meta-analysis of 11 LMCA studies also shown the same thing, significant reduction in mortality and primary endpoints with the IVUS-guided PCI. So overall, British Cardiac Vascular Society has done a national registry, 11,264 patients have LMCA PCI, and it suggests that there is 34% reduction in IVUS-guided group in mortality. And overall, if you go to C, there is definite mortality reduction by 50% when the 10 years data is produced. So there is continuous benefit which is increasing with IVUS-guided PCI. So IVUS-guided versus OCT-guided primary PCI in ACS that also shown to have significant mortality and primary endpoint benefit in 2 studies. In CTO also, though there is no pure mortality benefit, but primary endpoint benefit is certainly there. And similarly, we have this issue of doing a PCI in CKD patient, and there also, if we do there is a new concept which is devised by Ziad Ali, that if you do a PCI, no contrast at all, based using IVUS guidance, you can reduce the mortality by 25% if patient doesn't develop the contrast nephropathy. So these are all outcome data, and same way in ISR, if you use IVUS guidance, there is definitely mortality and MACE reduction, and various studies have shown that significantly. All-cause mortality is also reduced. Coming to impact on IVUS outcomes following a PCI in ISR, continuously there is a definite benefit and it goes over year. So in patients undergoing PCI, imaging guidance reduces mortality after stent implantation in almost every clinical scenario. Currently, we have almost 250 OCT machines in India and almost 500 IVUS machines. And we do about monthly, we do about 1,500 procedures, which are IVAS or OCT guided in PCI. And this number is slowly but definitely growing in India. And thank you very much for your kind attention.